It was, in fact, very pleasant. You will all be surprised because in Madurai University, Dr. Ashirvadam was the general surgeon. He wanted women to join general surgery. So I had a very pleasant experience with him, and I learned a lot from him, including vast history of general surgery and what the surgeons did at that time. That gave me an inkling into the true beauty of surgery, how they all suffered at that time. That made me think even our people in India must have gone through the same difficulties, but there was nobody to account for it, nobody to document it. But whatever happened in Britain had been documented very well. That's how I learnt about history then. Now, I'm so glad that all of you have decided to chronicle everything now. It will make a real mark in future. And that was my experience in Madurai. In Madras Medical College, also it was very similar. I worked under Dr. Vasudevan, who encouraged me, gave me full freedom to visit other surgeons' techniques and learn from them. And so I must tell you, it was very pleasant, or it is continuing to be pleasant with my colleagues working along with me, my friends, and my students, and those who work under me also. Maybe you might think I'm exaggerating a little, but no, this is a fact. This is how my life has been, and I'm enjoying it even now. When I was posted as the assistant professor at the Institute of Child Health and Hospital for Children, it is the largest hospital for children in India. And I found several infants, several babies dying in front of me. There was no infrastructure. There was no equipment. And the equipment that we got from Madras Medical College were all broken, repaired. So I thought something had to be done. And the government came to my help, the state government of Tamil Nadu, central government. And through them, I could get into World Bank and finally the government of Japan that saw the institute, were impressed with primary, secondary, and tertiary care in one building and decided to give 28.8 crores for just equipment, 250 equipment they gave. And our department benefited entirely because we got the best infrastructure. And that is how we were able to build up that department and continue. When I came out, still there were 700 children waiting, and I thought one center, which was well equipped, was not sufficient, and so I started the SOCAN. It was a difficult task getting not only the infrastructure, the team we were able to manage because all our friends from government hospitals joined together to do it. But the difficulty was to find a proper hospital with a proper infrastructure. We managed to get it in public health center. Now came the biggest challenge of all, funds. When I was in government service, I told you all the state, center, everyone helped, the bureaucrats helped. And so I was able to do whatever I wanted, try to find out how anemia, how hemoglobin maintained during perfusion was the real crucial factor which decreased mortality in children in the immediate post-operative period. That I learned with all the investigations, the blood gases done those days. The equipment used to be so huge and it had to be calibrated, solutions spent, cost was exorbitant. But I was able to do it because the government helped. When I came out, I realized that it was not possible to get funds like that. And so I went about contacting the government hospital, the government, state government itself. Had a few friends there who helped me and then started this public-private partnership with the government. And then with other components of society like organizations, philanthropists, campaigns, started collecting funds. Now I have a fund of a large fund of about 50 lakhs, from which I keep doing patients who are underprivileged free of charge. So I managed, and now I have a large fund, as I told you. And with that fund, I am doing surgeries continuously. And I get the patients from different districts of Tamil Nadu. My target population is India. So with my website and trying to let others know, patients are coming from faraway places, from different states, because they are all poor. I'm not concentrating on others. Just the poor come. I was mainly children I have started doing, but I started doing adults because some of them came and said that they needed, and their history was pathetic, and decided to do it. That's what I'm continuing to do now. We have a partnership with Children's Hospital Boston, who, with the IQIC and International Quality Improvement Collaborative, they help us in upgrading our knowledge of post-operative care and maintaining risk factors. Our data also goes to them. They come here, check our data. We learn from that hospital. Our anesthesiologist went there and refreshed his knowledge. I am proud to say I have a good dedicated team, because this is only for poor, and you can't expect that I pay very heavily. In spite of it, this team helps me a lot. And so that the first step, the anesthesiologist is back here, and we have started doing challenging cases in infants also. It has been an uphill task. It was very, very difficult to get these children, because they are all malnourished, and the respiratory infection, as you would all know, has been vexing, and we have found out ways. We have a shelter in a destitute home where they stay, and we make sure that they are prepared well before taking the surgery. We are following them up. We are documenting all these facts to find out when they become really normal with the cardiac function, physiology, everything. How long does it take? So we have documents to prove what we are saying, and that's how it's going on. Excuse me, I always thought this is nothing extraordinary. Anybody who would decide to do it would do it. And what we are doing is also not very, very different from what others are doing. What we are aiming at is perfection in what we are doing. We are trying to modify all techniques to tailor to our needs, to our forms, to our patients. And you know that the problems in India, whatever you learn from the West cannot be applied. What I saw in Roger Mee in Royal Children's Hospital, Melbourne, I couldn't apply it to Institute of Childhood. I found all those children dying in front of me. So I realized that if hemodilution is the factor that allows oxygen to be taken to the tissues, here they were already hemodiluted. And when you hemodilute them further when they go on bypass, the post-operative period was catastrophic. When I realized that, I cut short everything, the lines, the oxygenator, everything I cut short. And then realized that 7.5 grams of hemoglobin was a must. That was a watershed. And once I maintained that, the mortality came down. But now I realize when on bypass, even now I'm following them up, the same, if they go below 7.5, nothing really happens post-operative, because there are other risk factors. If they are maintained properly, you can really win. That's not a single individual risk factor when other factors are maintained. When I started, when everything was new, nothing was perfect. At that time, it was catastrophic. Now, the same hemoglobin can come down to 5.5. I need not fear if it's a short bypass. But we are very, very careful. If we go down, we bring it up immediately, and we are trying to be as safe as possible. as I told you earlier, this is nothing new. All of you would be doing the same thing. But what is different with me was I saw such children dying then, all of them dying right in front of me. But now I'm seeing them living. So I know the differences between the infrastructure and no infrastructure. In no infrastructure, it is terrible. Now you have ventilators to modify, you have so many things which can be done. And it's a pleasure to do cardiac surgery today. Blessed are all of you who are born now. You would learn more. And I saw that one of you had a fellowship in robotic surgery. It's great. See, the more the advances get developed and the better the management, it's a pleasure for the professional also and for the patient also. While I am determined to see all advances come to the patient population whom I am working on, all these are steps. And the surgeons who work along with me are younger than me. So probably they'll carry the baton onwards. And we are definitely going to see the underprivileged people who are really neglected get the best. That is our goal, the goal of Hearts for Hearts. And so can project. That's how we are going.
I really didn't work with Dr. Cooley. I was there in Texas Heart. There are operating rooms, which are about 10 operating rooms, and they're assigned to each surgeon there. I worked mostly in OR5. It was Dr. George Rule's operation theatre. So I assisted him in most of the surgery. It just happened that one day Dr. Rule's, the residents used to assist Dr. Cooley, and the fellows were assisting other surgeons. There were about 40 to 50 fellows in the center. So one day his resident asked me to scrub him, and I thought he's operating and he needs somebody to help him. So when I scrubbed him, it was a small baby being for a VST closure. And once the chest was open and baby was ready to go on bypass, Dr. Cooley scrubbed up and washed up to close the VST. That was the only time I assisted him or I saw him very close. But I did watch him doing a lot of aneurysm surgeries those days. He would do all, the worst aneurysms which were coming, but he would operate for 5 days continuously and then take a week off and go off to his ranch or somewhere else. So there was lots to learn that how one should work and how one should balance the life. And he would walk through all operating rooms. It's not that he kept himself aloof. And he'll come and ask questions while we were operating. He would ask, what have you done and what was it? So it was very nice interacting, but I can't say I worked directly with him for all the time that I was at PHI. There were very few women. There was no woman cardiac surgeon over there, neither as a resident nor as a fellow. So it was a sort of unusual for them to see from India a lady coming and as a cardiac surgeon, So I used to get lot of inquisitive looks. And the fellows are usually very good. They all mostly senior position. And they come there to see basically Dr. Cooley operate and then go back and do what they have learned. It was a very nice atmosphere. We had lot of patients in the beginning on, we were doing in fact on total deep hypothermia and total circulatory arrest. And the results were good with Dr. Cherian, although not so good, right, you would expect now. But at that time, he was the only one who could come out with 50% survivors or 60% survivors. And he was very honest with his presentation. That was what I admire about Dr. Cherian. And I have seen patients not waking up, going into coma. I had one child who became blind, when I was doing residency. It gave me a lot of heartache at that time. A 6, 8 months old child losing his eyesight. And fortunately, he recovered it spontaneously after some 8 to 10 weeks. We don't know what was the pathophysiology, probably some optic emboli or something. So I was, that time the articles were coming on these low flow techniques. And I followed those articles and I found Mr. Deborah, he was at Leeds that time, who was the chief investigator. So I corresponded with him and I wanted to learn that because that was the thing we were used to conventional bypass, plus the total circulatory arrest and hypothermia was quite messy. You had to cool the child in ice and everything was really messy in the theater. So when I went there, basically my purpose of going to Guy's Hospital was to learn that technique. And it was quite simple. All it required, and which we didn't have that time, was specific thin walled pacifico cannulae for cannulation so that you could keep sufficient flows and venous returns. And it seemed to work very well. When I came back, I had brought a lot of those used cannulae with me. We re-sterilized them and used them. And slowly everyone got used to it, and that's how it started. You would want to know something more? And maybe briefly what I feel I had thought to share with you was that you should really are doing great work. All of you, what I was watching, you are been very brave and courageous. And I think we had easy time because there were not too many women. And now as the numbers are multiplied because there are more voices coming in. So that's why you feel there is discrimination or something. Secondly, I don't know how many of you have seen the recent webinar on STS on women representation, global representation in cardiac surgery. Have you people seen that? It's a global problem, but I feel as the numbers increase, even men face these discriminations. There is no end to it. It all depends on the attitude, yours and the centers wherever you are training. So one should remain positive and harness your best energy. And find a support, whether it is a male, a female, it does not matter, in your specialty or outside, with whom you can really discuss your issues and find out solutions. And I used to call it action learning. That when you discuss problems, the solutions come out. When you ask the outsiders, they don't know what you are facing, and it's difficult to advise, that way. This is my personal feeling, but I really don't know whether there are something else. As far as they have mentioned a lot of pace differences, I don't think that matters. There at least didn't matter for me because I was working in a public hospital, municipal scales, or UGC scales, which was same for the men and women. I had a lot of support from all my colleagues, either seniors or my contemporaries, and I made good friends with outside Dr. Raj Tandon. He was a pediatric cardiologist in AIMS, Delhi. So, it's more you widen your circle, you broaden your own outlook also.
I've been hearing the real legends who have been there in India, that is Dr. Srimati and Dr. Ratna Mangotra, who also had happened to be my MCH examiner. So we have heard from them. So my experience may not be of that caliber, but I have had an experience which was it was very pleasant and a very nice journey all through the cardiac surgery career while I was from my starting in cardiac surgery until my retirement from Tirupati. So presently, I'm not in Tirupati, in Sri Venkateswara Institute of Medical Sciences. I'm working as Dean of Integral University in Lucknow, and I'm the Dean for the Faculty of Medicine and Health Sciences here. So I'm basically looking after mainly the education part, as well as I do a bit of vascular surgery here at the moment. So as my journey goes, um, choosing cardiac surgery as a career was a very big, uh, it was between two inverted commas, whether I should take it up or whether I should not take it up. But as I was doing my internship after my MBBS and when I was posted in surgery, my first posting was under a neurosurgeon. And I remember that in the very first week on the rounds itself, when he took me to the theater, he made me do a VP shunt. And I was really excited about it. And that was Professor Mazhar Hussain, who happens to be one of the leading neurosurgeons in Lucknow at the moment. I'm in Lucknow at present. So this is my hometown. So that was really fascinating. And then when I joined my house job in surgery, this was at Aligarh Muslim University, which is one of the central universities of India. So my first posting was in cardiothoracic surgery under Dr. M.H. Beg. And he was quite an enthusiastic young surgeon that time. He started mainly with thoracic surgery, so I saw a lot of thoracic being done there, including lobectomies, pneumonectomies. He used to do CMBs also once in a while. And I think at the time when I was doing my MS in general surgery, that was the time when. Anyway, so once I was in general surgery and working with Dr. Beg in cardiothoracic unit, I was really fascinated with thoracic surgery itself. And when I was about to finish my MS general surgery, the department had acquired a heart lung machine, and Dr. Professor Gujral from Chandigarh used to come and help Dr. Beg out with doing ASTs and mitral valves. So that was the start of cardiac surgery at Aligarh Muslim University. Though at that particular time, after finishing my MS in general surgery, I took up pediatric surgery. And I was working in pediatric surgery for almost a year and a half as a registrar. And then that was the time when I saw a bit of cardiac surgery at Aligarh. And when I came back home to Lucknow, my intention was to join MCH pediatric surgery, but I think my fate took me towards cardiac surgery. And I joined as non-MCH resident in Sanjay Gandhi Institute in Lucknow in 1989. And so I remained as a non-MCH resident for 2 years. And then I did join as MCH in 1991 and completed my MCH from Sanjay Gandhi in 1994. And thereafter, I moved over out of UP to Bombay. And this was the time when I really had a lot of experience working with Dr. Dev Saxena in his unit in Bombay Hospital. And I think that was the time when I gained a lot of confidence and a lot of techniques I learned from him. He used to give a lot of tips during and after seeing, when I used to do surgeries there, he used to give a lot of opportunities. So there was nothing like there had been a gender bias or they don't like girls. But Bombay always welcomed girls. That's what I felt there. And I had a wonderful time for whatever short duration I spent with him. In the meantime, I had applied at Tirupati and I was given a call to join as assistant professor in Department of Cardiothoracic Surgery in Tirupati, which was still a very primitive department at that time, though they were doing some amount of cardiac surgery. The number of surgeries they were doing, like I remember in my first year, they did about 38 surgeries the whole year. Next year, it increased to 52. And following year, then the sequence went up and the numbers went up to about 200, 250. And finally, by the time I left, we were doing almost 500 plus cases in Tirupati. So I have been operating pediatric, adult, thoracic, vascular, everything, because this was a teaching institute and we did have MCH also. So I had to do everything there. Just in case, because I had to teach my students also. Though there were not many students we got through, but yes, whatever we got, I have trained them. And one of them is Dr. Govini Subramani, who's in Chennai, and he's one of the transplant surgeons there, quite a well known one. So he's been doing well. There are few of them who have become professors in Andhra in their respective government colleges. So they also have been doing well. So I have been I have been on my own most of the time, and I have learned the skills from all my teachers. Then I have opted for some fellowships through the ICTS, that is the SS Anand Fellowship. So you can have some experience with very good surgeons. So I did go and worked for thoracic with Dr. Unikrishnan, and that was thoracic and vascular fellowship. So I had a very good experience of vascular basically with Dr. Unikrishnan there at Sri Chitra Institute. So it's not, I never went up outside India, but I have seen I have been outside India, but not on any fellowship or any particular term period, spending some time in foreign countries. Most of the skills which I learned were from my teachers only here, my seniors. And then later I took the Rebets Fellowship, for which I was in Bombay with Dr. Manke, Dr. Saxena. Both of them taught me a lot of skills in coronaries that time. And this is how I've been learning. And the only place where I went was Hong Kong, the Prince of Wales University, where on my own, and to learn the skills of video assisted thoracoscopic surgery. So this was all the experience which I gained through, and whatever was there was through books, like observing people operating, attending workshops live, and then coming and performing yourself in your own institution. So this has been there. And of course, later part of my career also, when I was professor, I just decided, let me appear for the National Board of Examination and see how much I remember the text. So I went and appeared for the National Board of Examinations in 2007 and got through it. And then, of course, now coming back home, because I had some other task on my other end, like building up a house and settling here. So that took me about a year and a half. So I took up a lighter job of an administrator. And this brought me to Integral University. I never went there. They only invited me. And I just look about take care of the education for the MBBS student, the postgraduate students. It's a new university, so we are getting up some new courses coming in. So it's a totally different experience right now. And we are going to start the cardiac surgery program here, I think in another year's time. And this is all I would say as of now. So the only thing what I felt was, as a resident in Sanjay Gandhi, of course, that was the time when myocardial protection was a big question mark. We used to use the crystallite cardioplegia, and sitting in the ICU, we used to see that a lot of patients are developing arrhythmias at that time. And slowly it was Professor Prabal Ghosh who got in the blood cardioplegia, then warm heart surgery came. So Sanjay Gandhi, being a new institution, was also in the learning phase that time. So this was what I would say. And when I went to Tirupati, I started with my own, they were using crystalloid cardioplegia at that time. And then there I introduced the warm heart surgery and the blood cardioplegia, and we did have much, much better results. So this is all I would say from my side. If any questions are there, I can answer them.
Delighted to hear so many living legends. As I was discussing with ma'am, Ava ma'am, that she has been a force of nature for all of us. Srimati ma'am, Ratna ma'am. I mean, it is a delight to know them, how they've gone through. When I started medicine, there were hardly 13 or 14 girls in my class who were inclined to do medicine, including me. And when I moved to MBBS, out of 100 students in my 100 student class, there were only 30 odd people who were who were doing MBBS. Post graduation, mostly my friends went to OBG. I went to surgery. In surgery, the male colleagues, they mostly preferred orthopedic by saying that it is the end specialty, ek bar ho gaya to ho gaya, and you're a specialist. People who went into surgery always had a issue, what next? To do MCH or not to do MCH? So women were normally not very happy to do that as a normal path. It was not a near norm kind of stuff, because by the time you are actually into it, you're around 25. You have a pressure of marriage. I have seen my seniors give through their marriages and everything, like it was work is worship kind of it. So the trend is changing now. Women are more into work-life balance. So people wanted to settle by the time they're 26, 27. Marriage was an option. And on top of it, there's an underrepresentation of women in neurosurgery, in cardiac surgery. Why? Because it's a long drawn path, a high stress job. Your parents will also tell you, why should you do this? There are better things to do than do this. Take care of children. When you join, your faculty will tell you, are you married? If you're not married, why don't you marry and have a house? I've heard all of it. I've done MCH twice, and I've done MCH, got only one degree, MCH cardiothoracic surgery, but I've done it twice for different reasons, which I will not like to discuss for the time. Not that because I was not good, because of what we call as gender discrimination. Gender discrimination can pose its head anytime in our life. The only way we can, go on top of that is, and also it was there because of a lack of, because we were not talking to each other, and there was that time a lack of female role models, mentors, and a perceived lack of opportunities. So what happened was, all this with just gender discrimination also turned its head inside. So I'm not saying that it is not part of other faculty, other professions also. It is there. What has happened over the time is, women have evolved. First, either they had to only choose their profession, or a married life, or children. It's been, if you go through these responses which we got, it's like, all over the place. People didn't prefer having children. People didn't prefer getting married. If they got married, they didn't have children. So it is changing over the time. Why? Because we have people who have done wonderful effort in this field. And also now, because of we can get out of this by promoting, having more initiative, promoting diversity, including everyone, and mentorship. And I want you to encourage women to pursue careers in medicine and become resourceful and have a good professional development. We, as the role models now, because we are the ones, we are standing right now facing the brunt or the influx of information, we can make it or break it for the next coming generation. We had it tough. We can make it easier for them by being their mentors. We can give them a better scope, give them a better feel as the next coming generation. So I want all of us to, join together and do this project together with us. In India, we have a very, a strange, very ajib kind of looking at way. If an Indian female is a doctor, they'll call her a nurse. But if their daughter becomes a doctor or clears medical entrance, they go on clapping, saying that my daughter has become a doctor. They want to see the heroine as a doctor, but they don't want their daughter-in-law to go ahead with a lot of stuff being a doctor, because they wanted to do the homework also. But with the gender discrimination coming down by good amount of education and get people getting sensitive to this thing has now really become very, very on a minor side with our flow. I would also now like to ask the next generation, which is in the second order of this thing, to give their valuable opinion. How are they managing all this? Thank you so much.
Hello everyone. I'm sure everyone is like in a hurry now because of the time shortage. So I'll go very quickly. After what I've heard of Dr. Srimati ma'am and Dr. Ratna, I think I am not supposed to say anything. They have beaten the odds and been there when we were not even born. So, in cutthroat practice, I mean, I would genuinely still say that it is very difficult to survive in private. I mean, medical colleges, even I now retrospectively wish I was in some medical college, but I am not. So, in private practice, to get patients, starting from patients to see beyond the breast, a woman surgeon can be a thoracic surgeon beyond the breast. That itself is a task. So starting from being a nurse, being called a nurse by the doctors, by the patients, and someone pointed out today in the group that women are right not, I mean, motivating. So women themselves, they are the first, sometimes the worst critics. So I think that with this kind of group, we should be able to join together and make things easier for our and the next generation to come. Because in thoracic surgery, at least, I'm not a cardiac surgeon, but in thoracic surgery and private practice, to make a name, to form a niche that you start getting referred thoracic patients, it takes a long time. It takes a lot of struggle, and the amount of efforts to put in are at least 3 to 4 times of any male counterpart. It just doesn't happen. So I have gone through it, and I'm quite happy with where I am. I've learned to be very satisfied with just doing good work. Maybe I do 3, 4 surgeries less than the contemporary, but it's okay as long as I'm doing a good job out of it. But I think this society, this group should join together and make things. Think that with something which I did good was, and which should be done, is choose a good mentor. So I was lucky in all 3 mentors when I had. My first was general surgery, Dr. Roy, who was head of department of Baba Atomic Research Center. He was totally in equalist, in fact, a pro girl surgeon, because he used to say surgeons, women surgeons have got better hands. So I got a strong mentor there who used to not hesitate to punish us either. I got a very good mentor in my thoracic surgery. I got Dr. Bhabatosh Vishwas who was one of the best mentors, very calm-headed fellow, but no difference between, no gender discrimination. And I got a very good mentor in the form of post my DRNB in form of Dr. Ramakant Deshpande, who's a Padma Shri awardee for thoracic surgery. And he used to say, you be a he, a she, or a it, I don't care, my work has to get done. So you have to be, for people who are starting out in private practice, take a pause. After your CTVS or thoracic training, join into a place under a good mentor for 3 to 4 years. Work, put your head down and work very hard. You start off a little late than your contemporary male people, because you will not get patients so easily. But the 3, 4 years after your MCH or your DRNB, if you are under a good mentor and you work it out, then slowly and steadily your practice will build up. There is just no shortcut to it, and there is no trick or tip for it to get patients faster. You just have to wait your time out. But to get the right, I mean, from trachea to esophagus, the only thing which has helped me is that Dr. Vishwas used to say that what your eyes cannot, what your mind knows, only that your eyes will see. So when you are not getting good cutting priya, just put your head down and read. So that is what helped me when I came on to doing work with Dr. Deshpande, and that's how I built up my practice. So once you do that, slowly and eventually the name will start coming up. That's what my experience is.
Hi, good evening, everybody. It's such a it's honor for me that I'm here in front of all the biggies, and I would also like to express my deepest gratitude to Dr. Srimati ma'am and Dr. Abhachandra ma'am. Dr. Abhachandra has been my examiner during my DNB days. So, see, I haven't prepared any slides, but with your permission, all of you, if you all permit me, I would like to introduce myself first with a few lines, and then I'll talk about my journey in short, just the highlights, if you're all okay with it. Is it okay?
Yes, ma'am, please do.
So, you all know I'm a consultant cardiothoracic surgeon. I'm also a philanthropist, and I have my own heart foundation, which is called Chopra Heart Foundation, where we have conducted around more than 200 medical camps, and we've conducted free complex cardiac surgeries even before Ayushman was out. And it was around like 190 to 200 people that I have done the surgeries for. by raising funds from some of my patrons and also my businesses that I am running at present, which are supporting my NGO. Being an entrepreneur, I'm the director of one of the companies which we are running called SER, the SRG Altus Use Healthcare Private Limited, and I'm also a consultant in Shankaracharya Hospital Medical College, and also in Sparsh Hospital here in Bhilai. And you're all aware that I'm a joint secretary in Indian Association of Interventional Cardiac Surgeons, and where we are pushing the surgeons to start interventional cardiac surgeons and take the things in their own hands. And apart from that, I have successfully pioneered one of the very complex cardiac surgeries, and those were done during the days of COVID, when all the news was filled with COVID, and so there was no buzz about it. But yes, I've done that, and before that, also some of the surgeries were done, but they did not see the light of day. I as a businesswoman, I have got around 5 businesses in healthcare sector and also in skincare industry. I was awarded Woman Icon of the Year in the region of Central India for giving for doing one of the finest some of the finest surgeries and some of the very complex surgeries. And talking a little bit about my marriage, sorry, about my life. Um, I um, I passed out I'm an AFMC alumni, and I'm a 1994 batch. I got married in 2000. My marriage was not a very good marriage; it was a violent marriage, and but later I lost him to a massive, extensive interval MI when my daughter was just 4. I raised her all by myself, and raised her while actually I was apparently living in the inside the hospital, doing the day duties also, night duties also, because and I used to be training a lot of technicians and all of that. I was trying to raise money to raise my daughter, so that's how I was living my life. Daughter used to stay with me inside the hospital in the ICU. Um, Finally, like I got through my PG entrance at Loni Medical College, which is in Maharashtra. But I experienced some kind of a sexual harassment, and I had to leave that place. But I fought a battle. I raised a PIL at the Supreme Court in 2009, and fortunately, the sexual harassment guidelines they changed. The Vishakha guidelines changed in 2010 based on my PIL, and I thought that I was feeling a little relieved after that. Then I realized that I had to go ahead in life. I always wanted to be a cardiac surgeon ever since, like when I was in my 10th standard. My mother is from nursing profession, and she had a lot of books, medical books and all that. One of her books had this chapter on infective endocarditis, and I read infective endocarditis for the first time when I was in 10th standard. So I had this kida in my mind that I wanted to become a cardiac surgeon. Then I went to Dr. K.M. Cherin after clearing my DNV entrance. He took me to the OT on the first day itself, and I learned so much from him. And he has been my inspiration ever since then. That time, I've assisted him in some of the all the adult and pediatric cardiac surgeries, even the heart and lung transplants. I got through my DNB CVT as 6 years at New York Hospital, Chennai. I landed there. I never told anybody about me having lost my husband. Everybody used to be very curious to ask me, like, are you married? Or where's your husband? This, that, and all. But I never told. I told that yes, I'm married and I have a husband. Because having told the truth, I would have exposed myself. That's what I felt. I would have exposed myself to duress. Already, a PG life is not all rosy and all of that. So I felt that nobody can touch me if I said that. So I was already, and before even I joined MEOT, I was already skilled because when I was in Bhopal Memorial Hospital while doing my residency, I was doing my residency in cardiology and cardiac surgery also. So I was already skilled in that. Plus, I was already skilled in surgeries when I was at FLL with Dr. K.M. Cherian. So I was skilled even before I started my DNB. But I had to experience a lot of biases against my colleague who was just a fresh joinee, and he had never seen the OT, who didn't even know how to hold the scalpel. But it's okay. I had some very bitter, sweet experiences, some very subtle biases. So I was, one day I was told by somebody, oh, you know what, you shouldn't have taken CTVS. Dermatology would have been best for you. So that really, troubled me. All of these things troubled me. Sometimes, debarring me from the OT. I used to be asked questions, and when I used to answer, so all of that, if I answered correctly, what do you think of yourself? What do you think? Even before I entered my cardiac surgery, I had already completed my PG diploma in clinical cardiology. So I was already seeing patients. I was doing the stuff. I was managing all the patients in the ICU. I was doing, pacemakers on my own, even when I was in Bhopal Memorial Hospital, even before my DNB. So there was this thing, what does she think? She knows everything or what? But I was like, okay, let me wait for the right time. And I left the place, after finishing my training. I did some hands-on in Southern Railways Hospital, and then again, KMC told me, Supreet, you have finished your DNB, now you have to come back to FLL. I was like, yes, definitely, definitely, sir, I have to. So I came back to FLL, but a very senior cardiac surgeon over there, I'm not going to name that person, made a very loose remark on my body. And that too inside the OT in front of everybody. The perfusionists are there, sisters are there, everybody's there. And I felt like, I felt very sick. And then I decided to complain and fight against it. But I realized that all the people that I was talking to, they were all females around me, and they were all okay about it. And they were saying that it was just a joke. Why are you taking me seriously? And I was like, no, no, baby, no, I'm not going to be here. So I put up a resignation, 24 hours notice, and forgoed everything else. And then I landed in Nagpur, Government Medical College, super specialty hospital. I got hands-on. Everything I was doing on my own. Everything, like whether it is adult or whether it is pediatric, all the cases I was doing on my own. My boss, my prof was like, so please don't call me in. I was like, definitely, sir, I'm not going to be calling you in. But what I realized was whatever I learned with Dr. Kemcheri, whatever I learned with Bashi sir, oh my God, how it saved my life. Everything, handling tissues and, thinking about the patient, thinking about the pathology, and then going in, doing the procedure 1,000 times in your head, even before you went to the OT, all of that has saved my life till now. And when I felt that I was ready, when I thought that I was ready, I decided that no more slavery. I'm just going to be building my own center. So I decided to build a charitable organization and all my businesses. Now there was almost like no help from anybody. It was difficult to arrange money for funding my NGO. So I decided that my own businesses will be the only ones to support. So I opened 2 hospitals, 1 super specialty, 1 cardiac center, 2 diagnostic centers, and 1 pharmacy. So I was very happy, and also like I've got one more company which is in the healthcare sector, and 1 skincare company. So all of this basically, whatever I earn, whatever we can afford, I transfer that to transfer in the sense like I fund my NGO through my ventures. So things changed for me. I started giving results because of whatever I learned from my great teachers, KMC and V. Bashi sir. And I've been applying skills that I learned from both of them. And I cannot thank them enough for that. They've made my life. So we were doing very well. I did all the rejected and difficult cases of Central India. I collaborated with the primary health centers and all of that, which were government hospitals and all that, to cater to the patients in the villages, etc. Today, my daughter is now like 20 years old. She's going to be 21 now, and I'm going to be 50 now. And she has now cleared her entrance exams in company secretary, because now she decided that she wants to be her own boss. She wants to do business. And I'm like, okay, fine, go ahead. I'm almost till like 50. I've decided to do only that much work and take on only those responsibilities that I feel will give me peace, will give me peace of mind, that make me feel that I've done a good job. I've done a good work. I'm not after numbers. I don't need anything. I just need to do good work because I want to die peacefully. That's my aim. So my aim in life is to perpetuate the knowledge that I have in health and business, and I will keep doing that till the end of my life. I'm not competitive. I only am living to do good work, make difference in people's lives, and leave a legacy. That's about it.
First of all, I would say that I never felt biased as a female at KEM hospital. Eh, In fact, sometimes I used to feel that they should sometimes treat me as a female because your bodies are different and you need some rest in during some time of the month and all that. But yes, it was a wonderful experience at KEM, and about the type of surgeries that were allocated to me, I never felt that I was biased. Uh, and then the main hurdle, or I shouldn't say it as a hurdle, but yes, pregnancy and the natural responsibilities and the natural feminine inclinations are not taken so well by the male society. I think they are not yet prepared for that, and it is our responsibility to prepare them for that. So I decided not to work during whole of my pregnancy and till I was breastfeeding my child. So I joined back when, you know, uh, I started weaning her, and more than my career decisions, I would like to share this experience with you all. So I wanted one more child, but I couldn't afford to. And yes, this is something which needs to be addressed. The male counterparts, or your male uh, partner, they are very much they do appreciate your work, they do want to contribute, but yes, they prioritize their careers, and still one of my senior had told me that, Gauri, look, that there is a breadwinner of the family, and then there is a alternate financial source. So that needs to be changed. Yes, my husband had provided me the option of taking the back seat, but I was not well prepared that time to take that challenge. But as a female, first thing I feel that you should make your male colleagues realize that yes, during the pregnancy we need rest, we won't be able to do certain kinds of duties, and that is not kamchori. It is required, and you should be allocated some clinical work, clinical research work, or something like that, so that you don't have to discontinue or lose the touch of the work during that period, which I felt, looking back, I feel I wasted that time. I could have done some clinical research, or I could have contributed in some other way during that. But yes, I had been blessed with great teachers like Joshi sir and Rao sir, and I'm trying to take it forward from wherever I am right now. I chose to be a cardiac surgeon after I got married, so that was out of question for me. But
Out of syllabus.
yes, it was out of syllabus, a bouncer. But my husband was pushing me to take up plastic surgery. He's an orthopedician, so he thought it would have been a good combination. But somehow my father-in-law stepped in, and then I could go ahead with my cardiac surgery thing. Again, pediatric was a tough decision. Like, you spend most of the hours at hospital, but my mother has been very helpful. But that's where you start getting that guilt that you are not doing your responsibilities as a parent. But I feel you should learn to balance your profession and your personal life well. uh, you should change the norms. Just because my previous generation has toiled too much and has spent too much time in hospital. That need not be the case with me. My general surgery was Dr. Madhuri Gore and Dr. Sandhya Iyer at Sion Hospital. So I never faced gender bias. That's what I said. Sometimes I felt I should be treated as a female. I was always treated equal, very much equal to the male colleagues. So maybe I was too fortunate in Mumbai at Sion and KM. I never faced that. Even in the private sectors with Dr. Rao, Dr. Joshi, I never faced that. In fact, in Australia, to uh, there were very fewer female surgeons and female. There was just one female cardiac surgeon who was working there. Even the number of resident female cardiac surgeons place in Australia, and that's when I realized, oh, females have a better. I mean, there is lesser bias in India than the Western world.
I'll just say about my work-life balance because I had to leave my work while I was pregnant in my first month of my pregnancy because I was having twin pregnancy and my gynecologist she told me that it's a high risk, so you have to either leave the job or you do lighter job or something. And at my workplace, there was no lighter job because alternate night duties, CPR, everything we have to give, and only that time I felt that yes, there is at some point we are different than our male colleagues because there is no pause in their career. I had to leave my job and I rejoined after 6 months, 7 months of my after delivery. So almost 2 years I was out of surgical hands-on or anything about my cardiac CT wave thing. So that time that was very that time it was very difficult to cope up that I'm not doing what I wanted to do. But again, afterwards, after last 2 years, 3 years, I'm back on. So just I'll just wind up because it's too late now, and I'll thank you all for just sharing my experiences.
So based on whatever, 2.5 decades of my own experience working with my female colleagues, what I feel, and this is something which I have also realized and understood from my female colleagues, is it is important that each one of us know our boundaries, limits, what amount of time commitment, what amount of professional commitment one is able to give to their profession. Two, we need not get into comparison mode with your male colleagues, female colleagues. It is important that we unleash our own individual potential within our given limits because, whether it is male, female, especially for females, apart from, getting into the business of multitasking at home and at workplace, which because of our own societal systems, male, gender doesn't get into sharing that, which, Dr. Priya mentioned in the chat box that it is time that we need to change mindset. But I'm sure that will happen over the period of years. But till such time, it is important that we do not get into conflicts of getting into comparisons with our other female colleagues who are able to achieve, because quite a few of them would be probably unmarried, so their level of domestic commitment may not be as high as somebody who is married, has kids. So important that we unleash our own potential in given circumstances. That is what will make you happy and satisfied in your professional life. Because I would talk predominantly from a public sector point of view, because the problems of a private sector are completely different. No patient is going to deny any kind of surgery or treatment in a public sector hospital, whether it is a male doctor, female doctor. What he or she needs is somebody who talks to that patient and gives him what is required. So from a public, and secondly, this is again my own personal opinion. I feel especially for female surgeons, public sector hospitals are a big opportunity because it gives you enough time for your domestic commitment. It gives you enough time for a lot of your other commitments. As I said, your EQ is much higher. The people who are coming to public sector hospitals, they need lot of emotional supports, which may not be the case completely in private sector hospitals. You have students who also need, kind of emotional support from you. Uh, and I'm sure there are quite a few senior surgeons who are, including Abhachandra madam, who has been part of public sector hospital for quite a long period of time, might agree that your happiness quotient will be very high in public sector hospitals because you are able to satisfy all your demands, your professional commitments, your domestic commitments, and many such things. Thank you.
I just have a few disclosures or disclaimers to make before I start. One is that my general surgery boss was a lady. Some of my best friends were my colleagues at that time. Then coming here, Abhachandra madam selected me to NIMS. I worked with Anita and I have seen her thing through MCH. And I've worked with almost all the lady surgeons at Nizams except probably for one, Usha ma'am. And right now I have almost 7 lady residents with me. So my wife is the first lady surgical oncologist of the state of Telangana. My mother and my sisters are all professors. So, if we are thinking that no discrimination against women exists, we are living in a different world. We see right around, probably we are just accustomed, so used to it that we have become insensitized to us. In every way, in so many different ways, discrimination does exist. There's no doubt about it. Look at how many, see how many talented women, what do you call discrimination? Working shoulder to shoulder with men was something which my mother did 50 years back. It is no longer working and equal pay. This thing is no longer what you call as equality. Equality is when you do justice to your potential, which you show as a school student or as a young medical graduate or a young MCH person. If you do justice to your career based on that potential, that is when I would call that there is no discrimination. That is when I would call that biases don't exist. So definitely biases exist. And we try in our ways to, a lot of people say that there's that equal opportunities. I say it should be equitable opportunities. It's not equal. It is equitable. And how do you do that? There are several ways for it. I just want to share on this forum because everybody knows what women are through. That's not a new thing. I just want to share certain strategies which I think might work in our workplaces. Because I happen to be a head of department at an institute where a lot of girls are now joining MCH. I want to make my workplace a very women-friendly workplace. And I want them to feel, I really wish to see their careers soar like so many of the other boys' careers are. What are the few things, Anita wanted me to stress, what are the few things I do to encourage that this kind of discrimination doesn't happen? First is, I think it should be communicated very clearly that, we have their back. The leadership of the organization supports women, not just in thoughts, but also in action. And no bad behavior against them would be tolerated at all. There's a zero tolerance to that. Secondly, we have to have a clear communication with them that yes, if you have any problem, please feel free to share with us. We'll try to help it out. I follow a principle that I never say no to any leave and I never ask them any reasons. Because I believe that even if you ask reasons, even for boys or girls, because if you ask reasons, probably they may not tell the truth. And I've seen that invariably my girl residents never abuse this. Whenever they want leave, they just inform me that I am not going to come. I don't ask them any reasons. And I have seen that they don't misuse this, and they work very hard when they are working. And all we see is, and they help each other out. If anybody needs a leave, all I say is hand over your work to your colleague, and they really help each other out. So never has ever has any work suffered. A lot of people complain to me that you grant them leave very generously. That's not something done in cardiac surgery, but I've seen that it never ever lets work suffer. I also make it a point never to ask anybody any personal questions. I'm a part of a lot of running groups, and then there I have realized that it's best not to ask. If people share, they share fine. We acknowledge it, but let's not every person is comfortable answering personal questions. So I don't make it. I make it a point not to ask anybody any personal questions. And yet, whenever the families come, I make sure that I tell their parents or their family that they have a wonderful career ahead of them, and I want them to encourage all the girls in their careers ahead. It is very reassuring for the patient, for the parents. I have seen, if we ask them to support their girls in their careers ahead. Many of them come and talk to me about marriage and all that. I say they are two different tracks. Just support her in her career. Marriage, you will always see what is best for your this thing. Just like guys, they don't link careers with marriage. Similarly, why should it be with girls? One thing I have also seen is that we have to be very generous in our praise of girl surgeons. You may call it a discrimination, but I have seen that, it's like a car driving. People say the guy is driving such a bad car, but they say women drive so badly if somebody is driving bad. So the converse is also true. It is assumed that if some guy does a good thing, he is appreciated. But whenever some lady resident or a lady doctor operates or something, the same kind of appreciation is not seen amongst the other members of the staff. So therefore, whenever I go, whenever we hop around in the OTs and we see some good job done, I make it a particular point to say that, oh, this is such good surgery you have done. I really appreciate it. And second, whenever there is some criticism due, I always say that you are such a smart resident or you are such a brilliant resident, but this is something which is not expected of you. I think that kind of reinforcement builds a lot of confidence in my girls as well. That is quite important. And last but not the least, I think it is very important for them to interact with peers who have succeeded. And one of the reasons why I have encouraged our residents to chronicle the odysseys of all the lady cardiac surgeons is so that they will feel motivated, they will feel encouraged. I always encourage them to reach out to seniors in the field so that they will also get motivated. Biases against them will go, and I wish that they have very wonderful careers. I'm really happy for this meeting.
Yeah, good evening all. I think it's already too late to hold you up anyway, and honestly speaking, both my experience and on the topic, I guess it's very modest, to be honest. But there's hardly much I can add to what already Dr. Abhijit and Amresh sir has spoken, and I really agree with a lot of points on what Amresh sir had spoken, especially the point that I think it has to be more. Equality is not the point. I guess it's more about equitability, and honestly speaking, I rather than beating around the bush, I can just tell one thing. It's more, especially coming from a private sector, all that matters is what you can, as it doesn't matter, it really doesn't matter what your gender is, what your faith is, at least in today's day and age. I guess I don't say, at least from my perspective, I don't see any I don't see a lot of discrimination, because I have seen, I've had the good fortune of seeing some excellent women surgeons, And I'm lucky enough, I've been very close to Dr. Anita already. So there's a lot that women already contribute in the field of surgery. So it really doesn't matter, I believe, your what your gender is or what you believe in. It's about what you can bring across on that table, what you can provide to the patient. Especially in a corporate sector, it only matters how many surgeries you can do, and how much of revenue you can generate, if I can put in a very crude terms. When it comes to probably a government sector, yes, you have a lot of things to deal with, a lot of hierarchy, you have many colleagues, so you have to work together with several of them. And perhaps there are a lot of differences, but I'm not the best person to talk about it. At the another thing what I can add in is, at the place where I trained from Narayan Hrudayalaya, Bangalore, and which of course one of the finest centers for cardiac surgery. And lately, what I had seen for the past couple of years at least, more and more women have been joining cardiothoracic surgery, taking up cardiothoracic surgery. I think the real challenge is not whether you're a man or a woman. In at least, I don't know what I've heard a lot of senior cardiac surgeons speaking, and I do totally appreciate what they're talking, especially what Dr. Chopra, she had shared a lot of her own, she had given a lot of insight of her experiences. But I think from now on and moving forward, I think what really matters, especially in cardiothoracic surgery, I guess, is how do we prevent uh, this brilliant department from keeping it afloat. I think the real challenge is, it's really unfortunate when people say this to me, but people do say this on my face, that cardiothoracic surgery now is a dying branch. Unfortunately, that we don't see a lot of people taking up. I mean, at least what it was 10 years ago, 15 years ago, 20 years ago, they don't have the same kind of demand for cardiothoracic surgery. I think the real challenge lies there, on how to keep this. I mean, of course there will be a lot of people still taking it up, but I think the only way forward is, I think with the help of technology. I think minimal invasive surgery is coming in, that will help a lot. Already I see that in thoracic surgery there's a new charm, and a lot of takers for thoracic surgery because of the advent of both VATS and robotics. And fortunately, the same thing is happening even in cardiac surgery. A lot of young surgeons are taking up interest in robotic cardiac surgery. So I think going forward, thanks to the foundation and the struggles that have been put in by the senior women cardiac surgeons, I guess that will really help going further the next generation, to fight the perils of I think it's more of corporate market factors, the corporate dynamics which will affect the cardiac surgeons, and it's not the gender. I honestly believe that. I think we're really in at a point of, I mean, with the events, the time is turning in such a way, the tide is going to turn in such a way. I have a very positive outlook. I don't think it would really, soon the gender bias is going to die down pretty soon. And yeah, all that matters is what we can what we can bring across. What is, as Dr. Amrish was saying, what is the potential, and whether we live up to that potential, what we had as training, and how best we can help our patients out.